So now we're going to turn to the future, the implementation of the Affordable Care Act. And doing the presentation on this topic is my colleague, Catherine Tier. Catherine is a senior program officer in our health reform and public programs area, which means she's one of Chris Perone's colleagues. And Catherine works on the portfolio having to do with the uninsured. She has some expertise in children's programs, in enrollment and eligibility projects and factors. And Catherine, come on up and tell us about the Affordable Care Act.
Thank you, Sandra. And a little bit more on my background. I, like Chris, have been working in this larger field for upwards of 20 years. My first work in the healthcare field was in the area of HIV and adolescents, and I continued to work on adolescent legal rights, and then moved into financing of adolescent healthcare and children's healthcare, and then I got older, and so did the populations I was focusing on. So happens to us all if we're lucky. So anyway, I am very, very pleased to be here. It is, as you all know, a very exciting and very challenging time to be working in the field of health policy. And it's a privilege to be able to speak with you today about these topics. As Sandra said, my role today is to speak to you about the Patient Protection and Affordable Care Act, which is a mouthful, and we usually shorten it just to the Affordable Care Act, or the ACA, and I have dear friends and colleagues who say Aca, but I've never jumped to that. But regardless of what we call it, you all know what it is to some extent. And as with the morning presentations, just a word that we will be covering this really at quite a high level. It's really an ACA 101. I know many of you have a great deal of expertise in this area, and I hope to hear from you in the Q&A period when we'll all be available to answer questions. So because although it was a short lunch, I know people do forget things as we go along. So, and since some of you I think were not here this morning, I just want to quickly go over a few key points from my colleagues' presentations this morning on the healthcare marketplace in California and on the Medi-Cal program. And the handouts in your packets for those of you who weren't there this morning include both Robbin's presentation and Chris's, and I encourage you to look to those for more detail if you want a refresher. So first of all, healthcare spending represents a growing share of the economy, and despite our high healthcare spending, quality and access are extremely uneven. As we discussed in the questions in an earlier period, we spend more in this country for outcomes that really trail those of the rest of the industrialized world. Employment-based coverage, or ESI, as I may refer to it later, for employer-sponsored insurance, which has been the basis of our insurance structure in this country for as long as we've had one, is down significantly in California, as we heard from Robbin, from covering about 2/3 of California residents about 12 years ago down to just over half today. The costs of health insurance premiums outpace the inflation rate by quite a bit. And yet we have millions of Californians who are uninsured. 20+% of our population under the age of 65, and obviously that means that they miss care that they need and incur financial burdens. So a few points on Medi-Cal, which are also going to be relevant to our discussion of the ACA today. Medi-Cal, as a reminder again, is a federal and state matched program with costs split more or less evenly between the federal government and the state government. It covers currently over 8 million California residents, most of whom are low-income families and children, and childless adults, as we'll discuss a little bit later, generally aren't eligible for Medi-Cal. It accounts for 1/5 of the state's spending in the general fund, and a small number of beneficiaries of the Medi-Cal program drive the costs in the program, accounting for more than half of program costs. So all of that is described, as I mentioned, in more detail in the slides that you have from Robbin and from Chris. So, the Affordable Care Act. It's in this context that the Affordable Care Act, federal health care reform, was passed and then signed into law just under 3 years ago. And some of you are probably already planning your parties for March 23rd, and I know I have my big Mylar balloons that say ACA, and others of you may not be planning any party at all, but should you wish to stop by, I will be celebrating. As you'll all remember, the law was challenged in the courts, and the cases worked their way to the Supreme Court last year. The decision in June of last year, 2012, upheld the ACA in large part, but it did make one important piece of the statute, the Medicaid expansion, essentially voluntary. Implementation of the ACA is really staged over several years, and so while we're all very focused on January 1st, 2014, as the time when the law goes into effect, that really isn't entirely accurate, as we'll discuss a little bit later. Certainly, some very important parts of the statute, including the biggest coverage expansions, start up then, but there are also pieces that have already gone into effect and others that will continue to unfold into the out years. So we must remain vigilant. We are not done come January, and there will be a lot that will continue to happen. This is tremendously ambitious and complex legislation, and even at the high level that I'm speaking at today, I'm not even going to try to cover all of it. My presentation today is going to focus on insurance expansion and the health insurance exchange, which here is called Covered California, as most of you I'm sure know. But before I get there, I do want to run through a few aspects of the law that I won't be covering in any detail today, because I think it's important to get a sense of just how far-reaching the legislation is. In particular, it has many provisions associated with financing, delivery system reform, the healthcare workforce, investments in prevention and wellness, and also reporting. And those are all things I'm not going to discuss, but just to give a few examples, the law reduces spending in the Medicare program, increases the Medicare payroll tax on high earners, imposes new taxes and fees on drug manufacturing and devices, imposes a tax on high-cost employer health plans. It tests different new ways to pay for and organize care. There's a number of provisions about healthcare workforce training and development. And finally, as I mentioned earlier, prevention and wellness provisions, which I'll come back to a little bit. So these were I forgot I had animated this, sorry. These were supposed to be popping up as I spoke. These are the ones in broad buckets that exist, and that's the only one that we're going to focus on in detail today. So I just wanted to give you that sense. There is more. So the issues that cluster under the general heading of coverage expansion are not small either. In fact, this is certainly one of the major and maybe the most central goal of the law. So as a reminder, and if you're paying close attention, you will recognize this slide from Robbin's presentation this morning. About half of California residents under the age of 65, and again, we're talking about under 65 because Medicare coverage kicks in over 65, have employer-based health insurance. And about a fifth are covered currently by the Medi-Cal program. A little bit under 10% purchase insurance coverage on the individual market, and in the gray, as I mentioned, about 22% of California residents under the age of 65 are uninsured. So here's how the coverage expansions under the ACA are expected to change that. And these numbers are from the California Simulation of Insurance Markets, or CalSIM project, which is a joint effort of UC Berkeley and UCLA researchers. And unfortunately, I don't have a separate, so visualize it as I talk through it. Between 1.8 and 2.1 million Californians will enroll in subsidized coverage in the California Health Benefit Exchange, Covered California. Somewhere between 1.2 and 1.6 million will be newly enrolled in Medi-Cal, so that green wedge, the 20%, will grow by a good bit. And thanks to those changes and some others, and assuming things go according to plan, the uninsurance rate among residents under 65 is expected to shrink significantly. So picture it becoming about the size of that orange triangle. It's going to go down to about 10% from the current a little bit under 10% from the current 22%. So that means that close to 90% of Californians under the age of 65 will have health coverage, which is a lot more than have it now. Flip side, the bad news, an estimated 3 to 4 million Californians will remain uninsured. And of those, approximately 1 million will not be eligible for coverage due to their immigration status. So while the ACA doesn't bring us to universal coverage, it does potentially go a very long way toward improving our current crisis of uninsurance. So coverage provisions, as I mentioned, some are new, coming up in 2014, and some are already in place. So there will be changes across all the existing coverage systems: individual insurance, employer-based insurance, and Medi-Cal. Some are already in effect, some are coming online in 2014. And here's some of the ones we've seen already. The Pre-Existing Condition Insurance Program, or PSIP. About 11,000 Californians with serious medical conditions now have coverage through this new program. They would have been uninsured absent this provision in the ACA. Children under 19 can no longer be denied coverage because they have pre-existing conditions. About 435,000 or so young adults in California under the age of 26 have been permitted to stay on their parents' insurance coverage plans. And I'm guessing there are those among you in this room who are either, I'm seeing some hands, who are benefiting from that provision right now, either as those children or their parents. And new policies that are being issued can't impose lifetime limits on benefits. Forthcoming in 2014, here are some of the things we'll see. New individual and employer responsibilities. I'll talk about those more in a bit. Additional insurance market reforms, also forthcoming, and I'll discuss some later. Subsidized coverage via the health benefit exchange. That's a big one, and one of the ones that probably you are most familiar with, and we're going to talk about that more. And finally, Medi-Cal expansion. The last one is additional coverage program options, the Medicaid Bridge Plan and or the basic health program. Those are two options for continuity of coverage for people who are moving above and below the line, the upper limit of Medi-Cal coverage. And those are quite a bit under discussion right now in Sacramento. I'm not going to go into them in detail, but we can talk about them later if you wish. So I'm going to run through three primary markets: individual, employer-sponsored, and the Medi-Cal market, and talk about how things have been and what we expect to see change under the ACA. First, the individual market, which, as you'll remember from the pie chart a few ago, covers about 8 to 10% of residents in the state currently. Right now, plans seek to attract healthy consumers, and they don't want the sick ones. I think all of you are probably familiar with someone who you know who is uninsurable, cannot get insurance because of a pre-existing condition, and that is how it works now. Consumers participate in the individual market as they wish, and not very many of them do so. Compared to employer-based insurance, premiums are very high, and coverage is typically less comprehensive than what you get through employer-sponsored insurance. And premiums vary tremendously by age. So those of us in the older age brackets get quoted a price if you've been through this process, and then you move along through the process and discover that actually that's not your price at all, and that it typically is higher and not lower. So what changes in 2014 under the ACA? Guaranteed issue. That means plans have to sell their products to people regardless of the people's health status. And so pre-existing conditions cannot lead to denial of coverage. That's a very big deal. Sliding scale subsidies are available through the exchange, through premium tax credits and cost-sharing subsidies. That goes up for people available to people up to 400% of the federal poverty level, which is about $45,000 currently for a single individual, about $92,000 for a family of 4. These are people who don't qualify for Medi-Cal and who don't have an offer from their employer for coverage that they can afford. An affordable ESI offer is what that's called in the lingo. The individual mandate, which is a very important, very controversial piece of the ACA, says that people must either carry coverage or face a penalty. And the penalties start quite low at $95 or 1% of your income in 2014, but they ramp up very rapidly to $700 or 2.5% of your income come 2016. These can be waived if the cost is too high relative to your income, or if you are uninsured for a short period of time. So there are some exceptions to the penalties under the mandate. And the idea here is to combat the problem that many have foreseen and that we've encountered in other insurance reform efforts of sick people seeking insurance and healthy people not seeking insurance. Because as you know, health insurance works by pooling the premiums that people pay in and using them to pay out the costs of a wide variety of people. And it works if you have people who pay but don't have many costs and people who pay and do have costs balanced. If you only have high-cost people in the pool, it does not work. So this is a recognition, the individual mandate, that sometimes you need the stick as well as the carrot. And finally, the ACA has various provisions that are designed to ensure less variation in premiums and in benefit levels, including rules about age banding and how much variation there can be between different prices for different ages, and some standardization of benefits. Employer-based coverage. I'll go through this quickly because Robbin covered quite a bit of it, but over time premiums have risen and offer rates, participation rates, and covered benefits have fallen. Offer rates are, does the employer offer insurance to employees? Participation rates are, does the employee choose to pay their share of it and to get in and get the insurance? No companies are obligated to offer coverage. Almost all very large firms with 200 employees or more do so, and so do most of the mid-sized firms, which have, say, between 50 and 199 employees. Small firms tend to be much less likely to offer, with only half of the smallest firms offering health insurance to their employees. Under the ACA, and beginning in 2014, large employers with 50 or more employees will face penalties if they don't offer coverage. Small employers will have access to tax credits. They have some already. They will have access to more. And they will also have the opportunity to participate in the SHOP exchange, which again I will discuss in a little bit. Medi-Cal. Chris covered it in detail, but again, the current conditions, eligibility and income requirements vary significantly by population. It's not well standardized. Most childless adults are not eligible for full scope coverage unless they're in the what we now call the seniors and persons with disability. The law tends to call it aged, blind, or disabled categories. And the eligibility standards are extremely complex. They look at, for instance, things like assets, what you own, as well as what your income is. Come 2014, significant simplifications. Income eligibility will expand to a uniform floor of 138% of the federal poverty level. Some people, you will hear both 138 and 133%. The difference is that while the law says 133%, it builds in a 5% little cushion, leeway, so it effectively comes out to be 138% of the federal poverty level, which is about $30,000 for a family of 4. In addition, foster kids will have access to coverage through the age of 26. They are covered under Medi-Cal currently, but as they age out, they often lose it, and that will be expanded. Simplification of eligibility rules. There will be a single standard for determining financial eligibility called the Modified Adjusted Gross Income Standard. It's up there as MAGI standard, and that'll apply to most people, not everyone. The assets test will be eliminated. That's been an extremely burdensome requirement for applicants and difficult to administer as well. As I mentioned several slides ago, the Supreme Court's June decision made Medicaid expansion effectively voluntary for states, but California is moving ahead with it. Decisions about exactly how that will happen are very much under discussion. The last thing is about the financing of the Medicaid expansion. The federal government pays for 100% of the costs of the newly eligible populations through 2016, and for most of it after that. Between 2016 and 2020, it ramps down from 100% to 90%, and then it stays there. There are, although I said I wasn't going to cover much else, I want to just mention a couple of ACA provisions that I didn't get to earlier. One is about the prevention-related services, and these include things like colonoscopy screenings, pap smears and mammograms, well child visits, immunizations, flu shots for adults and children, things like that, which will be available generally for free, sometimes at some slight cost. Enhanced payments to Medi-Cal primary care physicians in 2013 and 2014. And grant programs that I think, given time, I'm going to skip along through. So, the ACA also creates a new animal known as the Health Benefit Exchange, although you'll see it under other names. For instance, the Health Insurance Marketplace, which is coming more into use because exchange has proven to be extremely confusing to the majority of people, and Marketplace is still confusing, but it's a little better. And then here in California, we know it as Covered California. So what is it? Health exchanges are responsible for a very complex and diverse set of tasks, and depending where you stand and what you're working on, you'll probably have a different view on what their most central role is. But one way to think about it, which I think many of you will resonate for many of you, is that it does have some affinities with CalPERS system in terms of its functions, as I'll explain. So in its marketplace function, the health benefit exchanges allow consumers to shop for insurance among competing plans. And as a consumer, for many of us, this may be the most visible face of the exchange. But behind that, the exchange is certifying qualified health plans to be offered through it in both its individual and its shop side, as I'll discuss. And it informs consumers about the eligibility requirements for public coverage programs and does that eligibility process for premium tax credits, which are available only through the exchange, reduced out-of-pocket cost sharing, which is another form of subsidy that's available to lower income people, and exemptions from the individual mandate. As I mentioned, some people can be exempted based typically on affordability issues, and the exchanges administer those as well. Finally, it enrolls people in those programs for which they qualify. So these are federal definitions. Before I talk more specifically about some of these roles, I want to talk a little bit about the national picture. Because as you all know, I think the ACA gives states an option of either establishing their own health insurance exchanges or working with the federal government in one of two ways, either in what's called a partnership exchange, where the federal government keeps some pieces of the job and the states do other pieces, or having the federal government run it for them, which is the third model. So this is a brand new map as of last week from our friends at the Kaiser Family Foundation. And the darker blue states, including California, are those that have declared that they will be establishing state-based exchanges. Light blue are those planning for a partnership exchange, a collaboration with the federal government. And the kind of yellowy ones are those that are expected to end up using the federal exchange. So you can see we're in good company with, I thought it was 18 in the District of Columbia in total, but when I counted just now, it's 17 in the district. So. Exchanges, again, I'm speaking from federal law, serve two markets. Individual purchasers. As I mentioned earlier, many people under 400% of the federal poverty level will be eligible for tax credits through the exchange to offset their cost of coverage. And on a voluntary basis, which we haven't mentioned, all legal residents can purchase individual coverage through the exchange. And then the exchange also works with small employers through the shop exchange. They will be eligible for tax credits to offset the employer contributions if they purchase through the exchange. And again, on a voluntary basis, a small employer can come and purchase insurance through the exchange. One of the big things, somewhat less well understood, I think, is the exchange's important roles in standardizing benefit structures. So the way we talk about this is apples to apples. That is something that has been sorely lacking from the insurance marketplace in general, and the federal law is using the exchanges to try and bring some standardization in. So there's several important provisions around this, quickly. One is that all plans, inside and outside of the exchange, are going to have to offer specified essential health benefits, which are defined in federal and in state law. Plans have to conform to one of 4 precious metal coverage levels. And I so wish I'd been in the room when these were named, because I would have done something quite different. But these actually kind of correspond to my kids' soccer flighting. I don't know whether anyone else sees that. But anyway, they're based on actuarial values. And actuarial values are the percent of the total average costs of covered benefits that a plan will cover. So you've got your bronze that is at a 60% actuarial value, silver at 70, gold at 80, platinum at 90. And what that essentially means is that platinum plans, premiums will be the most expensive, and they will be the richest in the sense that the individual consumer will be responsible for the lowest level of out-of-pocket costs. And A bronze plan, by contrast, would be somewhat more bare bones in that it would be less expensive to the consumer up front, but the consumer would have a higher rate of out-of-pocket costs. So those are federal requirements. California goes a bit further in several areas, and I want to turn now to talking in a little bit more detail about our very own California Health Benefit Exchange, or Covered California. So this is Covered California's brand new website, and kudos to anyone who's here from the agency. I know it was quite a bit of work to get that up, and I encourage you to take a look and flip through and investigate it if you haven't already. I know it will be adding a great deal of additional features and new functionality over the coming weeks and months. So California was the first state in the nation to pass legislation creating a health benefit exchange. That was in 2010. It was branded as Covered California just a few months ago now in October, so that's a new name. And it is a quasi-governmental organization. It is governed by a 5-member board. Right now, the operations of the exchange are funded by federal dollars through grants, hundreds of millions of dollars in federal grants that the state has applied for and received. But in the long term, the exchange will become self-supporting. So the structure has to work in order for this to continue. As I mentioned, California goes beyond federal provisions in a couple of areas, and I will go through these pretty quickly because I know it's a lot of words up on the screen. Covered California will use a competitive process to select carriers and plans that offer what's called an optimal combination of choice, value, quality, and service. That's not true in every state. The state exchange has the authority to standardize products to be offered through the exchange, and there are certain requirements on insurance carriers whether they participate in the exchange, in which case they have to sell coverage at all those precious metal levels, both inside and outside the exchange. If carriers that don't participate in the exchange can't sell catastrophic-only policies, these are all provisions that are designed to ensure the financial viability of the exchange and maintain the competitive nature of plans within the exchange and outside. We can talk more about those in questions if you want. Enrollment also undergoes significant changes through the exchange, and is a big piece of work, a really heavy lift that the exchange has to do, has been doing, and will continue to do. And as I think most of you know, enrollment through the exchange is slated to begin in October of this year. So federal law has some very ambitious goals for what enrollment through exchanges is going to look like. Federal law describes a vision of real-time eligibility through a web-based application and enrollment system. And it requires a single streamlined application for all the insurance affordability programs, Medicaid, CHIP, subsidies through the exchange, et cetera. The federal government is developing its own application process that states can use, or states can develop their own as long as it's approved by the federal government. And at the same time that there's a single statewide application, there's also the first requirement up there for no wrong door to enrollment. That means the application has to be available for people to submit online, by phone, by mail, in person, and even by fax, because some of us are still using those. So there is some conflict there. I mean, really, it's a complicated area because sometimes it's difficult to reconcile streamlined with no wrong door. So at the same time that you're trying to put people through one process, at the same time you're trying to be open and available to them, to the very diverse population that may find for their various reasons that they want to apply one way or another. It's also complex because we are not starting from scratch. We are building on top of existing structures like the county eligibility systems for Medi-Cal. That said, it should be the case that the technology investments under CalHERS, which I name up here at the top of the page, which is the California Eligibility, Enrollment, and Retention System. Those investments, along with policy simplifications, should mean that the system is more consumer-friendly and coordinated than it has been in the past. And among those simplifications are things like using data matching where at all possible, in which electronically, the application will look outside and see whether the data that an applicant puts forward can be verified through an online source, which will save what has been a tremendously burdensome process of people having to bring in paper stuff like pay stubs. Similarly, the other verification pieces and increased coordination with public programs are part of this vision. But people are people, and outreach and enrollment assistance is going to be critical, so you'll be hearing a lot about that area of work in this year to come. Exchanges are required to do outreach and public education, to operate a call center, to manage robust websites, and have a navigator program. That's a program that gives grants to community-based organizations and others to do outreach. And then more recently, the federal government announced an optional in-person assistance program that's distinct from but related to the navigator program. So those are a big area of work for the exchange in collaboration with their partners in the Department of Healthcare Services and others, and the counties. So the road ahead, I think I've given you some sense of the really enormous tasks that all parts of the California healthcare delivery, administrative and governance structures will be facing just around the issues of coverage expansion. So 2013 is going to be very busy, in a word, and here are some things to watch. Decisions about what the Medi-Cal expansion will look like. Decisions about plan contracting under Covered California. The shape of the outreach and enrollment efforts, and also what the enrollment system itself is going to end up looking like from both a technological and from a policy angle. And I'm sure as many of you are as here have other things that you are paying attention to and concerned about going forward. So in conclusion, there is a great deal of room for improvement in access, in quality, in cost, in the way that healthcare is delivered and paid for in California. And the ACA gives us some very real options to try and make some of those improvements. It provides many Californians with new coverage options. But costs will continue to be a concern for many. And I mean not only the costs for individuals, because we have yet to see really how affordable these options will turn out to be, but also the system-wide costs and what's going to happen there. California has moved very quickly to establish its exchange, but has a tremendous amount of work to do, and things are moving quickly, and it is hard for people inside to keep up, and it is hard for people outside to keep up. Medi-Cal expansion decisions are pending and are tremendously important. It's an ambitious timeline. There's a great deal to do, and at the end of the day, unfortunately, many people will remain uninsured, and we can't forget that we need to have a system, a backup system, that this is not going to solve all our problems of access to care or even of coverage. So with that, I want to turn to a couple of resources that I want to point out to you from the California Healthcare Foundation and from other sources. So this is from a two-pager called What Californians Need to Know About the ACA, and we have other things online and additional pieces of information coming online throughout the year, so I encourage you to join our mailing lists and check back. We are, as Sandra said, always interested in knowing what you need to know and what we might be able to put out there that would be helpful and relevant. In addition to the items posted on the website, you can register for regular updates via our California Healthline and iHealthBeat. And those are digests of news and opinion, one kind of on general California healthcare issues, the other on technology's impact on healthcare. And if you're not familiar with those resources, I find they can save a lot of time. Specifically, we at California Healthcare Foundation are going to be working very hard to monitor and report on progress toward ACA-related policy goals. And this is just an example of one of the domains that we're going to be looking at under a project we've got on ACA implementation. This is on coverage metrics, and as you can see, we'll be measuring both within sort of across the California healthcare marketplace on the impact on uninsurance, on public coverage, on employer coverage, et cetera. And we will also be looking at accessibility and affordability in a manner similar to this. A couple of other resources that I highly recommend, these are not ours. One is Health Reform up in the top right, which is a project of National Academy for State Health Policy, or NASHP. And it's kind of it's kind of the Facebook for the ACA crowd, and it allows you to join up and post things and engage in conversations, ask questions from colleagues from within California, from DC, and from other states. And you can get a tremendous amount of information. And then below that, Kaiser's Family Foundation's State Health Facts, which is updated regularly and is a great source, actually, sort of in one place, even to find out what's going on in California and to find good sites to statute, to regulation, to policy papers, and to other RFPs, other things coming out of the exchange in particular. So with that, I will invite questions, and thank you very much.
Yes, I'm Lou Whitney with Sacramento ACT again, and we're working with the County of Sacramento. I'm sure they kind of consider us a nuisance sometimes because we're quite concerned about getting a strategic plan in place to enroll all the people that we want to, of course, get on the program by 2014. But they're saying, and I'm sure with some justification, we can't really put a plan together because we haven't gotten all the rules from the state, and we're stymied. Is there a bright light ahead for that?
Yeah, I'll start. Sandra may have more to say. There is some justification for that, and then I think, then it goes back upstream, because I know that all the states feel that they are awaiting additional guidance and policy resources from the federal government. So there is, this is the key problem with timelines. We're looking to do something enormous very soon without all the pieces yet in place. That said, certainly at the federal level, we have seen since the beginning of the year a very rapid output of things that I think, frankly, were being held back until after the election. And so things are starting to flow, and I think the same thing is happening with materials from the state. I know that staff at Covered California and at the Department of Health Care Services are working very, very rapidly, as fast as they can, to get out some additional guidance, particularly around these enrollment issues and outreach assistance. And I don't have the numbers in front of me, but I think, as many of you are aware, the timeline is moving along quite rapidly as far as the outreach and assistance grants.
I guess this would be just another chance to call out the good work by the California Endowment. Their board made a commitment of $350 million around implementation of the ACA, and I believe about half of that is going to outreach, and Marlon, who's here today, is one of the lead staff people on that. So a good problem to have, but yet another funding flow to coordinate as counties and the state puts together its planning effort.
And just one additional resource, I just wanted to mention that we will soon have forthcoming through our organization a kind of a primer on outreach and enrollment assistance and consumer assistance in California under the ACA. So you can look for that. We'll be publicizing it, and that may help with a single place that pulls together rules. So.
Question over here? Yeah, go ahead.
Hello, my name is Jim Bryce. I'm a freelance healthcare reporter, and I have two questions. First, how will the ACA affect current Medicare beneficiaries? If you could answer that one, then I'll follow up. So what effect will ACA implementation have on current Medicare beneficiaries?
Are you good on this?
I'll ask the second question later.
You're stretching our expertise here in that we really focus our work on California policy. There's a lot going on nationally on Medicare cost savings. ACA itself, one of the things it created was this opportunity for these dual pilot projects where there's been a concern for the 1 million people in California who are eligible for both Medicare and Medi-Cal, that you had one large program providing some of the care, and then the state federal program providing long-term care services, and that really we weren't doing as good a job as we might if those two programs worked together. So this federal administration has been very open to finally letting those two programs collaborate, and here in California there's interest in that. That's one tangible thing that this state is moving forward on. Chris, do you want to?
Well, and again, this is, I know a little bit about this, not my area of expertise, but Catherine alluded to some of the changes in the ACA that will affect Medicare. Another that's already been implemented is there's something called a donut hole in Medicare coverage for prescription drug benefits. And so one of the provisions of the ACA was the donut hole was there's coverage for costs at the beginning, and then you're responsible for your own costs, and then as your costs, prescription drugs get higher, that gets filled and gets covered. The provision was to close that gap some, but that's already been implemented, so it's not a change that's coming in 2014, but something that's already been done.
As part of the ACA.
What short list of questions should individual health care recipients in California have answered as we move towards October and the programs?
For anyone who's uninsured, understanding how the expansions in coverage, 20% of our population today is uninsured. So understanding whether or not they will be eligible for no cost or very low cost coverage through the state Medi-Cal program. That will be for people up to 138% of poverty, and that varies by family size. The second question is, am I eligible for a tax credit through Covered California? And that ranges all the way up to 400% of the poverty level, which really embraces all the income levels that we think of as median or average in California. You know, 400% of the poverty level is well above what most of us think of as poor, still low income, still needing of financial assistance, but reaching into probably many of us in this room. So people who are uninsured, they need to be understanding, do I qualify and how do I sign up? And that, as Catherine was mentioning, the whole CalHERE system, Covered California's efforts to get the outreach word out is going to start appearing late summer, early fall, when they have those health plan contracts negotiated, when our state legislature and governor have determined how Medi-Cal will be expanded. I think those are the most important things. On the private coverage side, those of us who have employment-based coverage, it's really understanding how the rules now of how health insurance is regulated are going to make it easier for us to change jobs and not have to fear that we won't be able to have coverage in our new jobs because we have a pre-existing condition. Those kind of things are going to be the most essential. But really, it's the big coverage expansion for the average person who either is uninsured or is looking to switch jobs and has a fear about being uninsured, or is paying a lot for their coverage today that may benefit by the new marketplace rules.
My name, again, is Nicole Rice with California Manufacturers and Technology Association. There is a lot of discussion when you talk about the ACA about individuals and how they will participate in the reforms. But as been mentioned today, a lot of individuals are still receiving coverage from their employers. So my question is kind of attached to what you just answered. What are some of the big questions that employers should be asking themselves or need to pay attention to as we move forward?
So as you saw in the data, just over half of people do receive their coverage through employment-based mechanisms. All the research that's been done of employers indicates that employers in general want to offer coverage to their employees. So why don't they all do it today? The answer has been the financial impact of that. So employers, as we all will have a requirement come 2014, the large employers and all of us as individuals, to basically figure out how can we get attached to coverage. So large employers, is it over 200? employers with over 200 employees will have a requirement to, over 50, to either offer coverage or they'll be facing financial penalties. So for them, it's going to be trying to understand what's the best way to do that, what's out there in the market, how does that meet their employees' needs. But employers really have a role. Today, one of the unknown facts about Medi-Cal is today there are probably over 1 million people in employment-based coverage who, by their income and their family situation, qualify for Medi-Cal. So one of the beautiful things about the ACA, in this woman's opinion, is it preserves these set of options. So people are going to have an obligation come 2014 to find out how to connect to coverage. Some are going to do it by taking advantage of the public programs. Others are going to stay in their employment-based plans. So again, for employers, really it's being sure that the information they have connects to these new offerings through CalHERS and Covered California, and so that their employees know what's out there and available to them.
I might just mention the small business tax credits, which are currently available and really not being taken up by a lot of small employers. So getting the word out as much as possible through your association or other groups about the availability of those tax credits is essential, because it'll really help those employers who are already offering coverage. And then post-2014, those tax credits go up. And I know the California Endowment has done a ton of work with the small business majority here in California to partner on outreach to small businesses. So Marlon and his colleagues would be a great contact for that.
Thank you, Michelle.
Has the foundation done any research that would focus on the potential of an employee with their employer figuring out what is the net income to them, whether they pay the penalty, the employee comes out, buys the insurance in the exchange? There is a potential, based on at least the initial numbers that are being posted on the exchange, there might be a value for the employee saying, don't give me the benefit as a tax deductible. Give me the cash, I'll get the subsidy, you pay the penalty, it costs you less, it benefits me. Has there been an analysis done along those lines?
Yeah, this is not an area of my expertise, and so, but there has been work done on exactly that issue, because in fact, yes, the incentives don't necessarily always line up such that the most advantageous thing for employer and employee is to have employer-sponsored insurance. One source for this is the work of the CalSim project that I mentioned earlier, which has done this work somewhat on the aggregate level in trying to model what the possible, to what extent employers might drop the provision of coverage that they currently offer. So I would direct you to that resource, and I'm sure from there you can find others.
And you'd find CalSim on a UC Berkeley site, ucb.edu.
Dr. Apgar, kind of a follow-up related to Harat's question. Has there been any analysis that's been undertaken about what some people have heard about the young male premium shock that may be experienced in the exchange itself? There's talk about young males currently covered in the individual market with the, quote, essential benefit design, et cetera, and with the change in the current underwriting that private payers are doing today, they won't be able to do that as much, so the premiums kind of line up. Young males in particular may have a significant increase, and are they going to drop coverage and pay the penalty?
This is a long answer.
Yeah, do you
So
want to take it?
So part of the insurance market changes have to do with compressing the range of prices. Today, a person in their 20s might pay a sixth of what somebody approaching Medicare age pays. And one of the interests of the ACA is to have those stair steps between age bands come together more so that there's not as big of a high to low. So how do you do that? You have to bring the top down and the bottom up in order to have less of a range. So that's where part of the concern comes from. Yes, there's been a lot written about how do young people in their 20s if they're going to be buying a benefit package that includes all of the 10 essential health benefits as articulated in the federal law, will that be more expensive than what they might buy today? So that's been a concern. I saw an analysis, I'm sorry, I don't recall, it was just in the press this week, a more recent analysis saying, yeah, that might all be true, but your income is highly correlated with your age. And if you are in that age group, you're very likely to be eligible for the deepest level of subsidy. So I think what the takeaway from that analysis is that they need to go back again and apply this greater understanding of how income varies by age, not for everyone. You know, there are some people in the maybe tech or the financial industries markets when they're in their 20s, but you know, many of us start out and our careers build. So trying to leaven that information on there to see what that, because to the extent younger people are the ones eligible for the biggest subsidies and the biggest protections in the law, it may mitigate some of that concern. But a lot of research in this and in the question that Hrant raised in terms of trying to predict what will we as individuals do now that we have an obligation to participate in the market, and what will employers do now that there are different kinds of federal subsidies available. So the question has to do with the basic health plan. I think Catherine and maybe Chris mentioned this. So in federal law, there's this concept that in addition to Medicaid, Medi-Cal, which can go up to 138% of poverty, and then the exchange subsidies that sit on top of that between 138 and 400, that for people between 138 and 200, that there might be a third program at a state option created called a basic health plan, and that would somehow maybe have lesser cost sharing than you might see in the exchange. The federal government recently determined that they would not issue any guidance on the basic health plan, I believe until at least 2015. They delayed it a year. So it really, for state implementation on January 1st, 2014, which is what we all collectively are tipping towards and running to that finish line, so there are new coverage options available. It takes the basic health plan off the table in many ways in terms of the federal guidance. Here in California, the governor has called a special session on health reform. One of the topics anticipated to be discussed in that is an idea of a bridge program, which might be a modification of this basic health plan, basically a way to provide lesser out-of-pocket costs to people that are at that lower income, but it would not be the basic health plan as articulated in the federal law.
Yeah, the questioner's mentioning that that one of the goals of something like the basic health program or the bridge program is to minimize what we call churn in the industry, which is the very costly for individuals and for the system loss of coverage as people move between programs or don't, just drop off and don't get back onto anything else. And so there are a variety of mechanisms, both in the law and in the way it's being implemented in California, that are designed to try and minimize that, and the bridge program would be one. Others just have to do with the processes of enrollment, with the idea that particularly to the extent that you're able to leverage big data sets and be able to electronically check on things and minimize the actual activities that a person needs to do to re-enroll either in the same program or in a different program, that will minimize churn, which has been a consistent problem in this state and everywhere else for many years.
Just as clarification, the CalSIMS information you're referring, is that Jacobson's reports, studies?
Yeah.
In which case, she confirmed, in which case I have a follow-up question on that. About 2 weeks ago, there was a similar forum, and Jacobson made a presentation, and one of the questions from the public was, how do we validate the modeling that Jacobson is doing? So far, it seems to be proprietary, the modeling that they're doing, though the information is not necessarily the data that they're gathering. So we have a huge system in California premised on a single model that is not validated independently. Is that something of a, I think the gentleman here was the one who asked the question. Thank you.
This is one of those cases where two things that seem diametrically opposed can be true. All that is true. It is a proprietary data set at this point. And we are the envy of most every other state in that we have one model by well-regarded, well-respected researchers that are making these estimates. So yes, we're big fans of open data and open source data, but you've described the situation.
I have heard very anecdotal accounts of employers reducing the hours of their employees so they don't have to meet the requirements to provide coverage. Could you talk a bit about the hourly requirements and any studies showing whether the accounts I'm hearing are anecdotal or widespread?
I have heard those anecdotes as well. This is not an area in which I go very deep, but I would certainly be happy to help you follow up and find some of those resources to try and put a little bit more research behind that. I don't know whether, Sandra, you have anything to add?
20 hours is where you flip into full-time?
Well, I think it depends, the hourly thing, but there is, I mean, and it is also true that come next year, it will be a little bit harder to make those changes in order to avoid some of the requirements. But the requirements are more stringent on larger employers than they are on smaller employers, and the numbers of hours that people work also apply. I believe someone else may have a comment on that.
Yeah, if it's okay. In the last couple of weeks, the federal government came out with a determination that it would be a 50 FTE equivalent based on the total number of hours of your employees, and it's going to go back to 2013 rather than the start in 14. So it's what you're doing now is going to count. So they trumped you.
Yeah, yeah, thank you, that's very helpful.
Leah Morris, I do some consulting for the Health Benefit Exchange, and also I'm a student at the UC Davis School of Nursing graduate program. I just wanted to suggest one addition to your resource list, which is the Health Benefit Exchange website, which I always have to remember the initials, but it's hbex.ca.gov.
It is. It is. I had on here the Covered California website. I don't know yet that links to all of what's been on the old hbex.ca.gov. Someone nodding that it does now.
We're not sure that
We're not
it
sure.
does.
So anyway, I would look
at
at both of those sources. This eventually everything will be integrated under this name. But in the meantime, it is true that the old website has a tremendous wealth of information, agendas, meeting minutes,
That's what I was
presentations, all of that kind of stuff. And I actually have not investigated this enough in the couple days it's been up to know whether it's also here.
Yeah, I just
Thank
was
you for
going to
that.
mention that there were several board briefing documents that if people
Yes.
wanted to dive in deeper to some of the activities, that's a place to go.
Thank you very much.
I just had a kind of follow-up question to the website. I've often heard of Cover California ultimately being operated like an Expedia or Amazon site where people will be able to go on. Do you know if that's going to be through this website or something else they might create?
I do not know exactly what the plans are for where the portal would be, but here's what I think you're referring to, is that there will be an online enrollment portal at which people will be able to do a variety of activities, from kind of looking around at what's available, doing sort of shopping without signing in, to going all the way through an application and enrollment process online. And some of the models that have been touted have been Amazon and Kayak and Expedia. Our foundation, in collaboration with a number of other funders, with 11 states, including California, and with the federal government, engaged in a year-long project called ux2014.org, which you can find on the website of that name, which was to design the front face of what an enrollment portal would look like. And That's been out in the world since last June, and California, among other states and the federal government, are using that in part to design their own. So I know that work is underway, and I imagine it will eventually, if it doesn't live right here, it'll be linked to from right here, or probably both.
Okay, we're getting the hook here. So join me in thanking Catherine for her presentation. Okay, we're going to wind up the day talking about, well, what else impacts health besides the healthcare delivery system, and what would we do if we were really dedicated to a healthier people and a healthier California? What's the bigger picture on all this? So Marlon, come on up here and introduce one of your colleagues for us.
Sure. Thank you so much. This is Marlon again with the California Endowment. And to the earlier questions about some of the, what should citizens know? I think it's important for folks in the audience to know that the California Endowment has really been engaging on a lot of outreach and education efforts through our partners and through our communications efforts. We currently have a partnership with Univision, which is the largest Spanish language TV network, which will air information nationally for the Latino community. We've also worked strongly with the business community. We have a website called Health Law Guide for Business, which also .org, which explains a lot of the benefits of the Affordable Care Act and information that businesses need to know. So we've been doing a lot of outreach efforts. We'll continue to do so as well in partnership with the exchange and with other foundations and other stakeholders. So with that, I had the privilege to introduce one of my colleagues who's been at the California Endowment for a long time, Dr. George Flores. He's really been at the forefront of a lot of our efforts, making the connection between public health and healthcare. And just really want to say thank you for all of you for being here. So thank you.
Good afternoon. Addressing the topic of the social determinants and health equity, in fact, population health, reminds me of a movie that came out a long time ago. How many of you remember MASH? The opening scene of MASH was based in Vietnam, and all of the casualties there. Flight surgeons were facing in one direction, waiting for the injured to come in so that they could take care of them. I mean, deeply traumatized soldiers having been battered in the Vietnam War. And while they're standing there talking, looking off in this direction, the helicopter comes in from the other direction and lands. That's a bit like our attention on health in this country. We're looking in one direction, looking for the insurance system and the medical care delivery system to solve all of our problems and create better health for everybody. And in fact, we're looking in the wrong direction because the medical care delivery system was not structured to solve all of society's problems, just like our educational system isn't structured to solve all of society's problems. Yet, that deep underlying basis for where society is ill and has too much stress and too much obesity lies in a deeper cause than just illness alone, than just something that a pill or surgery can fix. And that's what my story today is about. I'm going to show you a film. How many of you have already seen Unnatural Causes? So I'm hoping the rest of you will appreciate just this little clip.
There's one view of us as biological creatures, that we are determined by our genes, that what we see in our biology is somehow innately us because of who we were born to be. What that misses is that we grow up and develop. We grow up as children, we grow up as adults and continue. We interact constantly with the world in which we are engaged. That's the way in which our biology actually happens. We carry our history in our bodies. How could we not?
Living in America should be a ticket to good health. We have the highest gross national product in the world.
I'm very happy to finally have some of my cars in one location, some of them.
We spend $2 trillion per year on medical care. That's nearly half of all the health dollars spent in the world. But we've seen our statistics. We live shorter, often sicker lives than in any other industrialized country. We rank 30th in life expectancy.
Especially of economically developed countries, we are at the bottom of the list.
A higher percentage of our babies die in their first year of life than in Cuba, Slovenia, Estonia. How can this be? Is this just because 47 million of us have no health insurance?
Healthcare can deal with the diseases and illnesses, but a lack of healthcare is not the cause of illness and disease. It is like saying, since aspirin cures a fever, that the lack of aspirin must be the cause of the fever.
Or is it mostly because of our American diet and personal health behaviors?
Those behaviors themselves, in part, determined by economic status. And so our ability to avoid smoking and eat a healthy diet depends, in turn, on our access to income, education, and what we call the social determinants of health.
But wouldn't our genes trump social determinants of health?
Among twins who lived together until age 18, who basically grew up in the same households, so had at least a relatively similar exposure. If they diverged later in life, if one became professional and the other was working class, they ended up with different health status as adults. This is among identical twins.
Written into our bodies is a lifetime of experience, shaped by social conditions and policies that can determine who will be sicker, who will die sooner.
There are ways in which our society is organized that are bad for our health. And there's no doubt that we could reconfigure ourselves in ways that would benefit our health.
There are huge inequalities in the society. All this wealth is maldistributed.
Pet food, ice for the pets' water.
And I think that's in part why the US as a whole has relatively poor health amongst the rich countries, and why even the better off people are suffering. And we think that that is not inevitable.
Unnatural causes. Is inequality making us sick? Coming to PBS 2008.
So, as you know, 2008 has come and gone, but we're still dealing with the issues here. PBS has been carrying this series, and it's been extremely popular. Many people have taken up the cause of creating greater awareness about this inequality in our society. And I'm here to tell you a bit more of the story and about how the California Endowment is taking up this cause. We believe that health happens here, that our health largely depends on the conditions where we live, learn, work, and play, and not just in the medical treatment. Although certainly in the medical treatment, I'd be one of the first in line if I were in a car accident to go and look for a hospital to be treated. So there's no denying that we need medical care. However, there's more story than that. Health does not equal health care. Where you live matters, and it matters a lot. Life expectancy is the average lifespan a newborn can expect. And these different colors mean different life expectancies in the various countries of the world. For example, in the United States, the expected lifespan of a white person from birth is 78 years, but it's shorter than those people that live in Belgium and Denmark and all of the other countries, a lot shorter than in these other countries that I'm listing here. Why are we living shorter lives when we spend far and away more than any other country on health care? 26 countries are ahead of us in life span. In the United States, this is a map of US life expectancy by county. Between 2000 and 2007, more than 80% of the counties in our country fell in standing against the average of 10 nations with the best life expectancies. In other words, our life expectancy is getting worse in 80% of the places where people live here in this country. Does your zip code matter more than your genetic code? And you've seen this sign, you see it here on this stage, and you've seen it in other places, in the Sacramento airport. We're trying to create awareness through communications that really it does matter. The shape of health in our country, in our society, is determined largely by the conditions that surround us. There's been a long study in Alameda County based from the human population laboratory studies that have been long established there. 7,000 residents from 1965 forward. In other words, a good way to establish trends in terms of longevity and what is the background of these people and where do they live and what are they confronted with. And this is a map of both Contra Costa and Alameda County showing that in different zip codes and different sections, different neighborhoods within those two counties right here in California, there is different life expectancy by a magnitude of even up to 10 years difference if you live on one side of the town or another. We're using certificate of death to determine cause of death, and certainly it well establishes the date of death and so the life expectancy. And so we can tell where people have lived, what they died from, and establish life expectancy by this tract. So in fact, people in the foothills of Oakland live 10 years longer than the people nearby, a mile or two away in the flatlands. This is also true across all of California. Los Angeles County has this same gradient where people have unequal lifespans. Life expectancy by tract is also correlated to poverty. As you would expect, poverty is one of the social determinants, one of the things that underlie why people might live longer than another person. A poor person certainly would have lower life expectancy than somebody that isn't poor. In fact, life expectancy by poverty group can be tracked along a line, and you can see that life expectancy is longer if you look along the vertical axis for people with lower poverty rates. As the poverty rates increase along the bottom axis, life expectancy decreases. It decreases all along this trajectory so that we see groups with the highest life expectancy are those with the lowest poverty rate, and those with the lowest life expectancy have the highest poverty rates. That's true for the entire Bay Area, not just Alameda County, and it's true for California as a whole. So you can look at it a different way, that the cost of poverty in San Francisco Bay Area, for example, indicates that every additional $12,500 in household income buys you one more year of life expectancy. So the benefit appears to plateau above a certain level. If your income is above $150,000, then there's really not much more gradient. That seems to be sufficiency. But there are similar gradients in other places all across the country. But we're faced with some more disaster than even what I've pointed out to you here, that a potential decline in life expectancy in our country is facing us because of all of the different social factors, including the obesity epidemic and an increasing disparity in terms of life expectancy between the haves and have-nots in our country is foretelling even greater disaster. Because it's not just poverty. Babies born to non-high school graduate moms are more than twice as likely to die in the first year of life as a baby from a mom with 16 or more years of education. So education matters. Men with less than a high school education live 7 years less than men with a 16 or more years. Race and racism matters. You can see these two lines, the one on top are white people, the one on bottom, African American, traced over the years since 1960 until 2005. And those lines are getting further and further apart, meaning white people are living longer and longer, and black people although they're increasing in their lifespan, they aren't accelerating in that lifespan as much as white people, so the inequality is becoming greater. And the same thing with the life expectancy gap at each of these stages, showing you we began at 2.3 years in 1960 all the way up to 7.8-year gap now. That's almost 3 times the gap. Also, insurance, although it matters in terms of life expectancy, it also widens across the social gradient because even the insured, who are both insured and poor, live less long as people who are insured and not poor. So insurance matters, but it doesn't make up for the fact that you're also poor. And race and ethnicity gap also widens across the social gradient too, because different races have different life expectancies. Again, from non-poor, they're closer together, and as people are more and more poor, that gradient increases for all races, and pretty dramatically for African Americans, for example. The racial variation in premature mortality and disparities is pretty remarkable. And it's best understood as related to disparities in education, occupations, income, and the like. And it's strongly associated with outcomes. And it's so in every county across the United States, whether it's large, small, urban, rural, what have you. So looking at an international perspective, the United States suffers from shorter lives and poorer health. A recent study by the Institute of Medicine, which is one of the most venerated research institutions in our country and in the world, compared the United States to 16 high-income countries and found that here we spend far more for care and have poor health, die younger. And in fact, all of these conditions are worse among poor and minorities, and it's really not even so good among poor whites, or non-poor whites for that matter. All gradients of our society are affected by this poor health outcome, poor equity conundrum. Yet we spend more than any other country by far. As it was referred to in the Unnatural Causes film, we in 2010 spent $2.6 trillion of our GDP, of our economy on health. That's 17.9% and growing of our gross domestic product. But one of the major problems in this is $700 billion to $1.2 trillion. That's 30 to 40% of that spending is thought of being an excess spend in medical care. In other words, unnecessary medical care. Unnecessary for a number of reasons. In our system, we have, as you know, a lot of administrative costs, perhaps more costs than are necessary. We have fraud, we have abuse, we have, in a huge way, failure to prevent diseases and conditions that could and should have been prevented in the first place that we then have to go and treat. So all along the medical care spectrum, we're missing opportunities to save those dollars and put them into social spending, which is what the European countries and all of the other countries in the world that are better off than us do. If we look at public social spending in just a few select countries, we'll see that the United States spending is really below average, in fact, quite a bit below average across these various years from 1960 all the way to 2012. And why that is significant is because in most other countries that have, in fact, all other countries that have better health than us, their social spending is much higher than ours, and their health spending is much lower than ours, but they have better health outcomes. Longer lifespans, and in fact, if you look at them and ask them, they have more vacation days, people spend more time with their families, longer paternal leave, all of these kinds of things, and people feel that they're better off. So healthcare overspending and inequities is in a vicious circle because one leads to the other. Disproportionate medical care spending leaves resources for population health and inequity unstable and insufficient. This is the argument in policy circles, as you know, in Washington and here in Sacramento. Coming up with money for education or coming up with money for social programs is always a struggle. But coming up with money for medical care seems to flow when care is necessary for an illness that could have been prevented. There's almost never a shortage of money to go and make sure that gets served. Medical care spending does not even improve population health that much. In fact, there are other spends that, in terms of the health of the population at large, not necessarily of the individual who is sick at one point in time, but keeping people well in the first place and keeping them well over their lifespan is not even the job necessarily of the medical care delivery system, but rather our social and environmental and economic system. Having a job, getting an education, staying out of trouble, all of those things matter enormously to the population. So even a lot of medical care can't compensate for social inequities. But these disparities are only a tip of the iceberg. Lifelong effects of childhood adversity and toxic stress accumulate, and children carry this with them. There's a study called the Adverse Childhood Experiences Study that the Centers for Disease Control in Kaiser in San Diego actually initiated and looked over a million lives and of a million different people and found that the more adverse experiences of neglect and abuse and parents in prison or incarcerated, low education in the family, those sorts of things, the much greater, incrementally greater chance that child is going to fail themselves, to graduate from high school, to get in trouble with the law, to become a substance user, to end up in prison, and basically to have a less productive, less fulfilled, and a shorter life. So toxicity grows from children, and we have to think of that trajectory in early life as being extremely important. And it points to the stressors that accumulate. And the stressors is both an environmental and a biological pathway that wears on the body to create illness, emotional illness and physical illness. It creates these loads, these stress loads from social causes, lack of housing, lack of a job, stress in the workplace, stress in a family relationship, crime. All of these create problems in a pathway from the brain to the body. And it creates a hormonal imbalance that affects multiple organ systems and creates high blood pressure and pressure on your heart and on your nervous system. And it manifests in real life diseases and illnesses that land you under the care of a physician or a doctor or a hospital where costs are incurred for things that had originated in society, that had originated in your environment. And so the doctor or the hospital aren't treating the environmental factors, they're just treating the consequence. It's after the milk has been spilled and the cat's out of the bag and all of that kind of stuff downstream. And we're trying to put Humpty Dumpty back together again, and it's not very realistic. I've got a lot of kids' tales here. I've got a 5-year-old at home, so it works with him really well. The social ecology model is more or less what we're referring to here, where you think about the social milieu with economic stability and clean air and soil and water and adequate levels of economic and social development and healthy supportive family relationships and a nutritious diet. All of those positive factors matter in terms of wellness. They matter in terms of happiness. They matter in terms of physical and emotional wellness. And in terms of productivity. And let me show you a model that has been used in the Bay Area for some time. It actually originated in the Bay Area Regional Health Inequities Initiative counties in public health. And if you look, at one point we were looking at mortality on the far right-hand side of this with life expectancy and infant mortality. Those are really downstream results of what is going on upstream with race and class and gender and immigration. And in between all of that, we have these factors of institutional power and social inequities on one side, driven by family and culture. And on the other side, we have individual health knowledge and then risk behaviors, whether people have the knowledge and the ability to change factors or to not engage in smoking and nutrition and physical activity, inactivity problems, or violence and chronic stress problems that manifest in diseases. In other words, on one side of the spectrum, we have inequities in the sociological spectrum, and then resulting in disparities on the medical side of the spectrum. So getting back to the question, why are we unhealthy? Greater income inequality, child poverty, less social mobility, uneven education, holes in the safety net, communities designed around cars, limited access to primary care, more calories, less walking, more substance use, firearms and violence. All of those are really good reasons why Americans are unhealthy. And why health and equity matter is about equity and efficiency. U.S. has fallen to 5th in global competitiveness and 42nd in health and primary education. Because so much health is federally financed, poor outcomes contribute substantially to our federal debt, and growing inequities predict a bleak economic future. So you can see this cycle of inequity creating gaps, problems with productivity, which in turn create problems in our federal and state spending and in our ability to be productive and to get ahead. On the other hand, we have what's called the health dividend. This is the other side of the coin, that despite our wealth, the U.S. is unhealthier across the board than our peers, and there's evidence that flattening the social gradient improves health for all. That means that if we act to address those underlying factors, we can improve health, not just for poor people, but for everyone in general, because it can pull new resources back into society from a less productive part of society and reduce health spending. Transferring medical care overspend, for example, to social and infrastructure investment can both stabilize the nation's fiscal health and improve well-being. Let me repeat that. If you take that overspend in the hundreds of millions of dollars a year, and here in California it would probably be in the billions a year, and move that into social and infrastructure investments like primary prevention at the community level, playgrounds and places to walk, places to make sure people get healthy food, jobs, youth development programs, improving education opportunities. All of those things matter. Put back into the system would result in healthier people that have less demand on the health delivery system, are more productive in the jobs market, and lift up communities themselves so that they're more productive. And this helps the tax base for even the higher income people, and it creates more stability in our fiscal health. So we're looking at upstream interventions that, like policy in place interventions, that are promising. Let's repeat again the factors that affect health, and if we look at this pyramid, which was developed by the Centers for Disease Control, that counseling and education matters. People immediately go to brochures and TV programs or meeting one-on-one with your doctor or pharmacist and getting some good advice or a finger wagged at you. But really that has the smallest impact overall. It has impact and it's important to do, but it needs to happen in combination with clinical interventions and long-lasting protective interventions like immunizations and interventional kind of screening, and then changing the context, fluoridation of community water and smoke-free laws and tobacco tax policies that make a difference so that people don't really have to choose from having an unhealthy environment around them and don't have to encounter the risks. And then these socioeconomic factors like poverty, education, housing, and inequality. It's the base of the pyramid, and it has the largest impact on health by and large. This is recognized even by physicians. The AMA did a survey with Robert Wood Johnson Foundation and found that even physicians, to a great extent, wish they could write prescriptions to help patients with their social needs. If you talk to primary physicians, by and large, they know that they're handing out a pill or giving a treatment for something in many, many, many cases for something that is not going to really make that big of a difference unless they can find a big change in the person's environment, in their upbringing in the first place. So people are looking to the medical care delivery system for solutions and panaceas, going back and trying to fix things that should have been fixed in the first place in other sectors. So what surrounds us shapes our health. And taking a health and all policies perspective, and you in the state are really fortunate to have even a new Office of Health Equity that addresses this. The Health and All Policies Task Force was created as part of the Strategic Growth Council, a multi-agency effort under the last administration and carried forward into this one too, that addresses health inequities. It's a collaborative approach to improving the health of all people and incorporates health considerations into decision-making in the various sectors. The constructs are that intersectoral action for shared societal goals will get us where we need to go, with health implications in policymaking and planning processes, shared goals and strategies around the health determinants. And it's a win-win because in both the transportation sector or the agriculture sector, thinking about health as they make decisions in this health and all policy construct is going to be beneficial on both sides of the equation. Some of the active areas that your Office of Health Equity and the Strategic Growth Council are involved in have to do with transportation and housing and parks and community safety and healthy food, healthy public policy. And these are a list of the active groups, and I encourage you to call them in for giving you a rundown on what they're involved in, because it's very exciting, very forward-thinking stuff that a lot of other states don't have going on. And here's a blurry list of actually a very important piece of work that is going on in that office, and it's the indicators for what is a healthy community, what constitutes a healthy and equitable community. So it's not, if you notice, if you could possibly look closely, it's not a list of what diseases there are or aren't. It is a list of the fundamental factors that underlie health, like the social determinants. So it's about clean air and water and soil. It's about green and open spaces and living wage and robust societal and civic engagement, because those are the things that matter most in determining a healthy neighborhood and a healthy community. And so that's where we can aim our targets for what we want to achieve in creating healthier populations. That's where health happens. We believe in the endowment, health happens here. We're trying to use that as a catchphrase or a bumper sticker to get more people recognizing that all people in society have a role in this. Our collaboration for health and equity looks like the individual medical care system with its coverage and access and ACA implementation, health homes, community outreach. It looks like the public health folks working on health equity as a priority and bridging care to the community and doing health impact assessments and health and all policies. And the community health is reliant on empowerment. Power at a community level where the consumer themselves takes an active role in not only managing their own health care, but being a steward for better health, where they live, where their kid goes to school, where they work. All of that is around building the capacity in community residents so they can advocate, partner, steward, and certainly involve youth, because that's the coming generation. And we're seeing this work. Here are the places that we work, that we've had good results, where people come forward. And these are, in fact, in our world, very poor communities to begin with that had bad health conditions and bad social conditions, and where you wouldn't, and where many of the people have questionable immigration status. And you wouldn't think that these are the places where folks would come that have babies and kids in school and 2 and 3 jobs to come to community meetings or act on behalf of a community, because frankly, I'd be exhausted if I were in their shoes. But they do it. And look at these numbers of people showing up to actually participate in improving the health of their community. These are people who care and who are driven to that purpose because they can recognize that their action will make a difference, will improve the health for them and improve their wellness for themselves and their children. And so we're seeing new parks being built, and we're seeing sidewalks, and we're seeing health element in a general plan, and community gardens, and lots of changes, school wellness policies that are going to result in better health down the line. We each have a role with our jobs, housing, childcare, clean air, safe neighborhoods, and most of these are policy-driven. Most of them are policy-driven from a state, national, or local, regional perspective. So they all have a point in a decision process that you can influence, if not as a policymaker or a policy influencer, then as a voter. That's why health happens here, and we'd like to give you all the information you need about it and answer any questions you might have. Thank you.
Susanna Brower from the Center for Care Innovations. And thinking about, well, when the pyramid of the smallest to largest impact, as well as the diagram with the gears and the role we all play, if you could even break it down to, if you had some simple kind of concrete suggestions for tangible next steps, and I say that as coming from CCI, where our group works to support the safety net through grant funding, often the stewards of money from TC. What are ways that we can incorporate this awareness of the social determinants of health in a concrete way into our programs?
I don't think that the general public understands policy wonk talk. Health in all policies probably doesn't resonate in the households across California. I think we need to create new ways of connecting with people. That's why we use the Health Happens Here. We've done focus groups and found that people can relate. And I think that we have to do that in many, many ways when we talk about inequities, when we talk about health policy questions. So getting the change at the level where people who are faced with poverty or housing challenges, getting them to understand what needs to happen where they live is somewhat of a different kind of approach. The first approach, and the most important one, is to engage people where they live at the very beginning. Not to conceive of an idea and then come to them with it and say, I'm here to serve this up to you and I'm here to save you. But rather engage people and empower people, give them the tools they need in order to help create solutions for themselves. And this is what we've done in these communities, and it does take a while. It's not an overnight thing. But it wasn't overnight that we got to the predicament that we're in either. We've been spending this amount of money and over the years on health care almost without question for 30, 40, 50 years in this direction. We can certainly take at least some of that time to try to turn communities around and to use terms and approaches that will help communities lift themselves up and change the conversation with the general public about what it takes for our country to be healthier, happier, and more productive. And it is a change. This is transformational stuff. This is not business as usual. And it is disruption. It's going to be very disruptive especially to the folks that are in power or that hold deep economic interests in the status quo. They are going to resist very, 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 very hard changes that would change their incomes or change their stock profiles. But in fact, this is probably what needs to happen if we expect to become a healthier place, a more productive place, for that GDP to go down in proportion of health spending, and for our productivity as a society to go up. You're all, I'm sure, aware of the demographics in California, where our younger people tend to be ethnic minorities and of different races, very diverse, but unfortunately also lower academically achieving. And we have a serious question about how that population, as it grows and as the baby boomers age, are going to be able to be supported, how we're going to be served. So it's incumbent upon us really to find the answers of how do we involve both sides of that equation, both the population that will be the leaders of tomorrow and the agents of tomorrow, so that they can sustain actually a lifestyle that we believe that we want to continue. I'm sorry, very long answer. I hope that answered some of it.
It's very inspiring, and also
I hope so.
I feel the weight of the world on us.
No, this is exciting stuff. Let me tell you, I'm on a new Institute of Medicine committee that is dealing with population health, and just had our first meeting this morning. And people have a lot of energy about this, believe it or not. The youth, in fact, perhaps the most inspiring of all, is seeing these videos, because kids communicate now through social media in a huge Twittering and stuff that way beyond me. But they love to make videos, and they love to get together in groups. And in Fresno and in Santa Ana and East LA and all over the state, we've got groups of young people, junior high, high school, college age, that are getting together and have tremendous energy about improving that, about changing the system. They really have it in their spirit deeply and energetically that something new and different is going to happen. Because really, it is depressing, and it is very much a downer to think that they're going to have to move into a system where the economic prospects are poor, where the cost of education is out of sight and is going to end up with an enormous debt, where they're going not to live as long as their parents, and that is one reality facing us right now, living not as long as your parents. My gosh, how depressing can you be? So youth, I think, is our answer. And we need to really direct our resources there to energize that group to save us all.
All right. Well, join me in thanking Dr. Flores for that great overview. All righty. You guys have been great. I have to ask you to pull out that green piece of paper, fill out your evaluations. Be sure to tell us what you'd like to learn more about. How can we be useful? What can we do? I want to thank Marlon at the California Endowment, thank my colleagues at California Healthcare Foundation, but mainly thank you for your interest and enthusiasm today. And we look forward to seeing you at our next briefing series. Thanks.